Okay, so I'd like to welcome you on behalf of UCL Psychiatry, the Lancet Psychiatry, Black Thrive and the Mental Health. Today we're going to be discussing a very important topic about racism in mental health, and if you had a chance to have a look at the Twitter feed, you can see that it's kind of creating quite a bit of conversation. So the COVID-19 pandemic and the momentum of the Black Lives Matter movement has really brought conversations about racism to the fore. And, you know, these conversations shouldn't be reserved solely for the criminal justice system, but it's also relevant to mental health research. So we've got a great panel today, and no doubt our discussion this evening will be fire. So you might feel a little heat in your seat, but if you are feeling uncomfortable, it's not necessarily a bad thing. What I would ask is for the duration of this session, if you could try and lean into that as much as possible and be open and stay curious. And I'm confident that you'll find it was worth it, because this is some of the work that we need to do to make mental health research racist, or anti-racist, not racist. And so we want this to be a safe space. So please ask questions, and I'm sure that you'll find this a really useful session that will give you some practical ideas about how to make research anti-racist. So let's get this show on the road. So first of all, I would like to introduce you to Professor Stephanie Hatch. She is the Professor of Sociology and Epidemiology at King's College London. She leads a program on marginalised communities and mental health at the ESRC Centre for Society and Mental Health and the Health Inequalities Research Group at KCL. Her mental health, her research is focused on discrimination and other forms of social adversity, community mental health and inequalities in mental health and health services. She currently leads the Tackling Inequalities and Discrimination Experiences in Health Services study funded by the Wellcome Trust and the ESRC, which is currently focused on the impact of COVID-19 on racial and ethnic inequalities experienced by health and social care workers. So welcome, Stephanie.
Thank you, Natalie.
So the question that I have for you is, what is racism and how does it manifest itself in research?
So, of course, racism has multiple definitions, but the definition I'll offer up today is that racism is an ideology, a structure and process involving systemic subordination of members of targeted, socially constructed racial or ethnic groups. Racism operates within and across systems and institutions at interpersonal levels and is internalized. For mental health research, whether it is your topic of your research or not, the reality is that racism is historically embedded in the foundation of all systems and institutions in which we work. It's embedded in the economic and the social foundation built through colonialism and slavery. Racism, importantly, is a life course exposure that is often witnessed, experienced, and anticipated from a very young age. For many of us, racism is the earliest and most pervasive exposure to adversity, manifested often through prejudice and discrimination. And so I also want to importantly note Dorothy Roberts, Professor Dorothy Roberts, Professor of Law and Sociology at University of Pennsylvania, recently made this comment on Twitter. Racism, she says, quote, "Racism isn't the product of race. Race is the invented product of racism." And in terms of the way that it manifests itself in research, that happens in a number of ways. So racial inclusion in mental health research continues to be elusive. There are apparent gaps in race-related research, a disproportionate lack of funding on race-related research, especially before the pandemic, and also apparent in how race-related research is conducted, the scope of the research, the interpretation and contextualization of the research, and how we are incorporating this research into our teaching. And in fact, at the beginning of the pandemic, many of us were surprised, not including myself, because it's something I've been going on a lot about, about how little we actually knew about the mental health inequalities affecting racial and ethnic minority groups. So where was the evidence when we needed it? So it's important to look to the past and think about how we got here. And it's one of the things that is striking to me is that the last comprehensive nationally represented survey of racial and ethnic minority mental health in the general population in the UK was conducted nearly 2 decades ago. And that was the empiric study. So importantly, that study had an ethnic boost sample to deal with the lower sample size, but it did not present findings for substantial racial and ethnic groups in this country, such as those who identify as Black African. So we've been relying on detailed mental health data from the Adult Psych Morbidity Survey, which requires us to pool data across all racial and ethnic groups. And even when the data is pooled, it can't examine important areas and mechanisms. As a result, we rely also heavily on electronic health records, which represent those who have been in contact with services, but is limiting our understanding in terms of the level of need in the general population. We are fortunate that we have several high quality qualitative research studies, some conducted by my fellow panel members, and I hope that they'll go on to talk about that. I also want to say that it manifests itself in terms of the training and education pipelines. It's evident in the limited opportunities for students and trainees to conduct race-related research. It limits career progression in terms of mental health research. We've seen a loss of talent in some cases and poor retention. And I also want to note just recently, recent related reports, such as just recently on BBC Newsnight, but more importantly, detailed in the Leading Routes report entitled The Broken Pipeline, showing that Black applicants for PhDs were much less likely to be offered studentships, among other disturbing disparities. So to conclude, it should not be okay that we don't know the level of mental health need of specific racial and ethnic groups in the general population. It should not be okay that there has been a relative lack of investment in race-related mental health research to address this gap in our knowledge and evidence. And it should not be okay that we are basing recommendations for policies, interventions, and services on evidence from mental health research that does not adequately represent racial and ethnic minority groups. Thank you.
Thank you, Stephanie. That was a really, really kind of comprehensive overview of racism and how it manifests itself in kind of research. So next, I'd like to introduce Chelsea Mcdonough. She is a student at the King's College London, and she's currently doing her MA in education. She's also the Education Policy and Campaigns Officer at the Traveller Movement. So welcome, Chelsea.
Thank you, Natalie.
Right, so I'd be really interested to hear from you in kind of also thinking about what Stephanie has also said. In what ways does racism in mental health research affect the outcomes of Gypsies, Roma and travellers?
I think what we see is, we see really there's a silence in the literature. So there often isn't any research. It's reliant on smaller scale studies. So when she mentioned kind of even some of the more government stuff that's gone on, the data collection is not consistent across services. So the NHS does not record travellers and ethnicity in the NHS data dictionary, which means we have no idea of what the actual the health outcomes are. So we have smaller scale studies that are saying, suicide rates are higher than the national average. And anecdotally, we know this to be true. But there's no data to back this up. And part of that is to do with how travellers are understood. And I think, so when I talk about Irish travellers specifically, we have to be understood through the lens of British colonialism in Ireland, but also the oppression of PAVI peoples, that's Irish travellers, by the Irish state. And this is important in understanding kind of why we're silenced, but also some of the research approaches. we often, we're assessed and I would say misunderstood through the gaze of outsiders, And this comes, back to this understanding of whose understanding of wellness are we talking about? Whose systems to promote wellness are we using? Are these institutions free of violence and oppression? Or do they enact a different kind of violence? And I think for me, these are questions I think about. And I think about mental health a lot. I lost 2 uncles to suicide. It is the norm. We have normalized that. But it isn't normal. And I think it's a reaction to a lot of things. And oppression is part of that, and a big part of it. And I think people, because travellers are, Irish travellers, and we'll talk about specifically, are a white minority. And we do have to consider how whiteness plays within that. But it means that you're not considered in kind of broader data collection. And there's almost a general kind of apathy towards it. Generally, travellers are almost seen kind of as responsible for their own situation. And it contributes to mental ill health. And unfortunately for us, that silence is being paid for with the lives of Gypsy, Roma, and traveller people, and the trauma that is left behind in families. And how many tears have to be shed before people care? We care as individuals, and often kind of more broadly, people don't really care. And for us, it's an epidemic, and it's been ongoing for a very long time. And I think it's that kind of general people not caring that results in that. And yeah, it's a very difficult topic.
Yeah, thank you so much for sharing your story and also your perspective around kind of what some of the challenges that research and the way in which it is framed and the invisibility of the traveller community in research and data more broadly, how that then also plays out in terms of the lived experience and the inability of the system to respond to the community's needs. So I think that's kind of so important, and it really kind of is a really important segue into our next panel member, which is Professor Dawn Edge. Hi, Dawn.
Hi.
Hi, welcome. So Dawn is Professor of Mental Health and Inclusivity in the Division of Psychology and Mental Health at the University of Manchester. She is the academic lead for equality, diversity and inclusion, with a particular focus on matters relating to race and students. She chairs the university's Race Charter Mark self-assessment team and oversees its implementation. Dawn's research interests centre on reducing inequalities, which include exploring the intersections between our social identities and determinants of health and illness, and also in terms of approaches to building resilience and the factors that influence access and treatment outcomes. So Chelsea sort of mentioned about the kind of invisibility of the traveller community in data and in research. And I just wondered if you could also share what some of the consequences of the hypervisibility and invisibility of Black people in mental health research.
Okay, well, thank you. This is another really big question, isn't it? And there is a bit of a paradox here, isn't there? That on the one hand, in particular parts of mental health systems, particularly at the coercive end of mental health care, Black people are hypervisible. So many of you will know that your risk of psychosis, of being diagnosed with psychosis, if you're of a Caribbean origin in the UK, is about 7 times, depending on who's doing the research and what kind of measures you use, but it's about 7 times higher than the rate for a white British person. And that's not people who've just arrived from the Caribbean. We're talking about people whose grandparents and great-grandparents came from the Caribbean. And it's not dissimilar now. The rates are climbing now for people of Black African, sub-Saharan African descent. So really pretty shocking. So, and that's linked to the way people come into services. So very often under blue light. So the police are involved. They've been sectioned under the Mental Health Act. At kind of 4 times the rate of white British people. And that, I think, sets up in the mindset of some practitioners, or rather confirms in their mindset the link between Blackness and dangerousness. Some of you might have read, and if you haven't, I really recommend the book called The Protest Psychosis and How Schizophrenia Became a Black Disease. And that's really worth reading, about how over time a condition that used to be primarily diagnosed amongst white middle class women shifted its focus and became a label attached to Black men around the time of the civil rights movement. And so, not surprisingly, not just a coercive end of mental health care, but also the prison system overflows with Black people. So that's a hypervisibility. But then in terms of the invisibility, you've got, and Stephanie's already alluded to this, that there are whole categories of mental illnesses where we know very little about Black people and their mental health. We just don't see them. And even in the hypervisibility categories, there's a lot that we don't understand. We know a lot about the epidemiology, which is often not problematized. So it's presented as, you know, as a fact rather than maybe looking at some of the other things that are going on in the process. But that aside, you know, I did my PhD in perinatal depression because I wanted to know how come I didn't know any Black women who talked about ever having postnatal depression or ever being diagnosed with postnatal depression. For a long time, practitioners used to say, and there are still some who hold to the myth that Black people don't self-harm. And we know that neither of those, those just two examples, we know that neither of those are true. Certainly the work that I did, about a quarter of the women in my sample met the threshold for diagnosis with moderate depression, mild to moderate depression. And whereas in terms of suicide, that we know that whereas white populations report higher rates of suicidal ideation, the rates of completed suicide are higher among young Black men and middle-aged Black women and South Asian women also than their white counterparts. And we also have invisibility in the research agenda for service users. So very often people who are labelled as hard to reach, and you know, for a long time we've known that that randomized controlled trials, it's really difficult to recruit people. This is the story, it's very difficult to recruit people from UK ethnic minorities into those trials, but they go ahead anyway. So maybe we'll pick that up in a little while. So moving on, so policy and practice, so invisible there. So especially Caribbean people, there are a lack of psychiatrists, psychologists, occupational therapists, and those key professional roles. Policymakers are not visible there, or commissioners. Senior leadership in the NHS is still regarded, you know, can still be said as the snowy white peaks of the NHS. It's still that's the case. And I've already mentioned research. So in terms of research, and this again, Stephanie has alluded to this, you know, what is published and what is seen as valuable. So the kind of research that I started off doing and still really enjoy doing, which is talking to people about their experiences to better understand and inform service development. Qualitative research doesn't even feature on the hierarchy of evidence, which has randomized controlled trials at the top. So people's voices are missing. And that means that and also when those studies are published, they tend to be published in lower impact journals. And that means you get limited funding. You know, that has implications for people's research careers. And that also then informs who becomes academics, how you progress through academia, and ultimately who gets to sit on those funding panels and, you know, research councils that set the research agenda. So it's invisibility all around, and I think, you know, the ultimate consequences are is exclusion and marginalisation from entire groups of people from the research process from start to finish. And I'll stop there.
Brilliant, thank you so much, Dawn. So I think that's given us an awful lot to think about in terms of even what we think about in terms of what we mean by invisible or hypervisible. And I guess what you've outlined is that it's at every aspect of the research process, not just thinking about who happens to be within the sample of the study. So the next person I'd like us to welcome is Saida Akhtar. She is a trainee clinical psychologist at the University of Oxford, She's a mental health researcher and project coordinator at Mental Health. Her research interests include ethnic inequalities, the mental health of Muslims, the experience of carers, as well as service user and carer involvement in the research process. So welcome.
Thanks, Natalie.
Hi, so thanks for joining us this evening. So I think, like, you know, as I said, like Dawn was talking about, you know, the invisibility and I suppose the importance of having that representation across the piece. And I think often when we're thinking about kind of communities, we tend to fixate on a particular kind of identity. And so I was quite interested to hear from you how an intersectional approach may help us to address racism and other forms of oppression within research.
Thank you, Natalie, and thank you to everyone who's joined us tonight. Yes, an intersectional approach is incredibly important as we think about how we can be a bit more anti-racist in research. So I'm sure everyone is well aware of the term intersectionality, which was put forth by Professor Kimberly Crenshaw a while ago in the legal domain to describe how different forms of oppression can overlap and compound one another, creating these unique experiences of discrimination that can't be explained by just focusing on just one part of a person's identity. I think as human beings, we tend to hold multiple identities. I'm sure everyone here can at least identify 3 different parts of their selves. And with it, each part of it brings its own set of difficulties or privilege. When we focus on just one form of discrimination, so for instance, just focusing on race or social class or disability in research, what we do is we ultimately risk privileging some experiences and marginalizing others, leading to a poor understanding of mental health difficulties in certain populations. And actually, when we have these poor understandings of mental health difficulties in certain groups, particularly those that are marginalized, that then feeds into policy and the practice as well, which then leads into the experiences that people of colour have in general within mental health services. And by ignoring all of the different parts of our identities and the different types of discrimination that we experience, what we do is we essentially leave behind lots of voices that need to be brought to the fore. So for instance, we can focus on just race, but then what about people who are, for instance, disabled and also a Black person or a South Asian person? We've seen this in the COVID-19 pandemic and the fact that lots of people of colour are more likely to be to contract the virus, but also die from it as well. We've seen how when we look at race and gender as well, we see how women and men from different ethnic backgrounds are treated in mental health services. For instance, if we look at Black men, they're more likely to be seen as dangerous within services, and we see South Asian women who are more likely to be dismissed. And adopting an intersectional lens allows us to add that nuance to the work that we do and address the multiple ways in which people can experience discrimination. It allows us to give a voice to those who may be otherwise overlooked, and it allows us to develop richer conclusions that actually reflect the real lives and struggles of people. And by doing so, what it means is we can engage more people in research and in helping us to create better practices and better mental health services to serve people of colour and marginalised communities better.
Brilliant. That was really, really, really insightful to kind of summarise intersectionality in a few minutes. You did a sterling job of that. So thank you so much. Engagement, yeah, lots to think about as always. So next, I'd like to introduce you to Professor Frank Keating, who is the social work and Professor of Social Work and Mental Health at the Royal Holloway University of London. He has a very kind of important and has made a really important kind of contribution to our understanding and knowledge, in particular around kind of Black mental health. And I'd be really interested to hear from you around the process of decolonizing knowledge. So our speakers have spoken quite a bit about the difficulties and the challenges around the whole knowledge production process. And so I guess it would be helpful for us to understand, well, what does it mean to decolonize knowledge, and why is it important in the mental health research context?
Hi, Natalie, and thank you very much for inviting me. As everyone else said, these are rather big topics and to discuss in such a short time. But I'll be quick. Decolonization or decolonizing in the university context is now talking about decolonizing the curriculum. And it's often very narrowly interpreted. And so it's about, people think if I add a few Black authors to my list, that's it. And in research, it's if we include a few Black people in our research, then we're okay. And if we have a Black researcher, that's going to be okay. Decolonization and decolonizing knowledge is broader than that. For me, it's breaking down the structures that maintain the status quo. So the structures that support institutionalized racism is what we need to break down. And we can do this by analyzing how oppression and how power is used to exploit, discriminate, oppress racialized groups. So that's the first thing about decolonization. And the second thing about it is one needs to examine and challenge the beliefs you hold about other groups, because decolonization is also to check othering and how that happens and how we can stop the processes of othering, but also how we can value the views of other groups. So that's just in general, and I can talk more about this. But when we come to mental health, it's about challenging and analyzing how Euro-centric ideas are used to inform research. And I think Suman Fernando argues this very clearly, Western models of mental health doesn't always apply to other groups and people from different cultures. So that's quite important. And for me also, and this is alongside other people who argue this, decolonizing mental health research is about disrupting the alignment between ethnicity and mental health. Ethnicity is not a risk factor for mental health. That's a myth, that's wrong. What is a risk factor for mental health is the adversity that comes from ethnicity. So the discrimination, the racialized trauma, the exclusion, the marginalization, those put Black people at risk for mental ill health, not the ethnicity. So we need to really disrupt this alignment between ethnicity and mental health. Dawn talked about the invisibility, and I think what we need to do is make race and racism visible in research. I would also encourage white researchers to explore how white privilege operate to reinforce racialized discrimination. And if we want to decolonize mental health research, we need active involvement of racialized groups in the planning, conducting, and implementing of research. Thank you.
Brilliant. Thank you so much. Thank you so much. Yeah, and I think it is really quite interesting, isn't it? It's just not about having visible diversity within the research process, but actually really thinking about how we can disrupt and fundamentally, the structures that hold the inequalities, in place, even in the process of our research. So last but not least, I'd like to introduce Moise Rocha even. I'm so bad at this, it's terrible, but welcome.
Thank you.
Super. So Moise is the PhD researcher, from the University College London. He's exploring the psychosocial dimensions and cultural factors that shape how people of Black ethnicity experience dementia, with the overall aim to improve experiences and outcomes by delivering a framework of an inclusive, culturally informed dementia care pathway. So your research sounds fascinating and absolutely necessary. And I was just wondering, kind of thinking about what the other speakers have already kind of said and drawing on your own experience of the work that you're doing, how does racism impact participation and the knowledge production in research?
Thank you, Natalie. Well, as you mentioned, lots of quite a few of the factors that influence how racism would affect research has been sort of listed or talked about tonight. But one side that I'd like to sort of concentrate on is our research is conducted. We do tend to approach it in a very racialized way, particularly in this country. Now, we would tend to use race or ethnicity. Ethnicity is quite linked to race as a variable, even when this is not necessary. And unfortunately, what happened, usually we create sort of categories, or we use existing categories rather, which were not actually created for research. And what we do, we sort of merge everyone together. So, I mean, in this country, we use people of, well, a bit less people of color, but more BAME, Black, Asian, and minority ethnic people. So in a sense, what we do, we create a dichotomy between everyone who is from the white majority population and everyone else. So we have created literally two races that we analyze research around that. And as quite a few of the panelists mentioned earlier, we create a narrative and we come up with some findings, and then we sort of label that group of minority with all this narrative around it. And then we suddenly all share almost that same commonality of being a problematic sort of group. And in fact, what that does as well is that when you try to, for example, looking for people for research, like I think was it Don mentioned that you get those sort of label where it says that minority ethnic population are difficult to recruit. They don't access services. And if we try to recruit them, that would require too much time, too much money, would cost a bit too much. So with that sort of label, not only it doesn't help, because if you're part of this group, you tend to sort of just think, well, if they think this is how I am, I may as well not participate. But also on the researcher side, researchers find themselves a little bit more hesitant, more circumspect into trying to involve minority ethnic population. Now, I have to use that term, but I don't like these terms because, you know, when you use minority ethnic population, BAME, you merge people that are not supposed to be together. You just merge them and say they're all the same. And I'm sure everybody would agree that the experience of a Black person who was born in this country is will be totally different to a South Asian or Gypsies. I mean, yet we put them all together and report research like that. And another one of the problems that creates is the fact that, you know, when you read a report, for example, the latest COVID report, you have to read it really carefully to know who exactly they're talking about. You know, when they say minority ethnic population are higher risk. Now, the official sort of meaning of these terms includes people who are white, people who are Black, people from different countries. And then when they say that, you don't know who exactly they're talking about. I mean, who exactly get ill? Is this, you know, are the Irish included, the Gypsy included, are the Black African? And you usually come to the point in asking yourself, why would we actually use those sort of labels to carry research, if not to simply separate a group of people that do not share the same skin tone as the majority population? I I only have 2 minutes, so probably I should stop.
Thank you so much. Thank you so much. Like literally, you have all like blown my mind. I have loads of questions, but I think I've had my fair share of asking the questions that I'm kind of really intrigued to hear from you. So if you do have questions, please pop them in the Q&A function. So the first question, and I probably would like Stephanie to answer this one. So this is from Vicky Kuna. She says, how would you suggest challenging silence in organisations with regards to BAME issues? Sorry, I have encountered a lot of silence from non-BAME when trying to introduce BAME topics. Even with reassurance, it's difficult to open people up to this important topic.
So to put it bluntly, I suggest that you challenge them loudly in contrast to their silence. Particularly in the last 8-9 months, I have had to have this conversation multiple times, often at the university level. You know, even people with the best of intentions usually approach me with they approach me with how uncomfortable they are, and use that as an excuse for their silence, to which I remind them about what it takes for me to be in predominantly white situations all the time and for most of my lifetime. So if they think they're uncomfortable, imagine what we feel like when, you know, particularly as a Black academic and in these spaces talking about issues of race, I'm often the only Black person. That hypervigilance that I have to keep up to engage in these conversations within predominantly white institutions. So there's, you know, I don't know if it's me being American or what, but I give up. I've tried the more subtle approaches, and I just decided, you know, to support people in finding their voice, and to speaking loudly about this, and also making it very clear to people that, you know, we definitely would like support and people to be allies. But what they cannot expect is for us to do the emotional labor for them. That's something that is very important, and it's important for our mental health, because I will reiterate that this is something that's been happening to us and we've been witnessing and experiencing from a very young age. And it's this process that is relentless. So we just need people to acknowledge that in these spaces in which we're talking about it.
Thank you so much, Stephanie. You probably saw me clapping, but I was like, yes, yes. Like, honestly, like it's, I think people don't necessarily really appreciate like the trauma that you have to endure. And I just think it is important when we're thinking about, even when we have this whole thing about a safe space, who is this space supposed to be safe for? Because actually, as we're walking around society, we're not safe in most spaces even. So thank you for that. So the next question I have is from Sean Frudist Walsh. Sean says, papers mention people from Black Caribbean backgrounds as having risk factors for psychosis in the UK. I feel that this language is problematic, and it seems to suggest that being of Black Caribbean ethnicity in itself is a risk factor for mental health. There are studies showing that there is little to no increased risk of psychosis in Black people living in the Caribbean. Should there be more emphasis on how being a victim of racism in all its forms affects mental health risk? I don't know who fancies taking this one on.
I'll start. So I think the point about looking at the risk in the Caribbean, and now increasingly we need to do it for Africa, as the African people in the UK, as their rates are rising, it's really important to acknowledge that. So there has been for a long time, the way we studies in the UK have been reported, it's been Black Caribbean people have high rates of psychosis and schizophrenia in particular, full stop. Now, the fact that the vast majority of the people they're talking about actually aren't Caribbean, they're Black British people, or they're people of mixed or multiple heritage who were born in the UK, so they're not Caribbean in that sense. They have Caribbean heritage, but they're not Caribbean. So we continue to mislabel people. And I think the fact that people from the UK have gone to the Caribbean and collaborated with researchers there and found that in comparison with the global prevalence of psychosis, generally, and schizophrenia in particular, there isn't an elevated rate, says that there must be something here. And yet the research that's been done doesn't really address that. And when you look even now at studies that are being reported, too many of them have a migration hypothesis. Whereas when we're talking about Black British people, where have they migrated from what, Brent to Lambeth or Manchester to London? Where? Do you know? It's that kind of stuff that when these things are getting published, then nobody's asking these questions. Why are we still talking about migration when the vast majority of the people in our services were born here? So I'll pause there and let somebody else speak.
Yeah, so it's such an important point. But yeah, I don't know if anybody else has anything to add, or I can move on to the next question. I'll take silence as agreement. So before the webinar, Kate Atherton put forward a question which I think is on quite a lot of people's minds. So we've had, you know, we're often kind of referring to communities who are racialized as Black, Asian, or from minority ethnic backgrounds as hard to reach. And so she asks, I've struggled to recruit a representative sample in the past, despite actively trying to. Where might I be going wrong? So does anybody on the panel have tips on, you know, what people could practically do to increase representation within their studies? Moise?
Yeah, so I think I can probably try to help with that one. People say that quite a lot, and have been recruiting Black, African and Caribbean predominantly in UK, and I have to say in the last 6-7 years, I haven't had any problem with that at all. Now, so the question is, as researchers, do we have to update our sort of perspective or our ideas about what it is, what it takes to recruit? Where do we recruit? Now, one of the, it depends on perhaps on the area you research, but one of the places that is quite easy to find minority ethnic population or Black, African and Caribbean will be through your GP practice, because practically everyone here is registered with a GP. We tend to also recommend to go to a daycare center, depending, you know, organization. But one of the concern that I have is if you tend, that may be a little bit controversial, but if you do not have any sort of contact or interaction with a group for your entire professional or personal life, and suddenly for research you need to contact them, even that becomes a little difficult. That would be a bit like me trying to recruit a group that I have absolutely no contact or no relationship with, and that becomes difficult. So I do believe there's an input. It's kind of important to have people with the same sort of background or similar background to help with that? Or to run research within those groups?
Thank you, Moise. Stephanie, I think you were interested in contributing.
I would say that starting that process at the point at which you start a research project is too late. So we started, and it's something that I am incredibly grateful for in terms of the training that I had in research from the beginning of my studies, was about having an ethos and a thought about reciprocity and sustainability with the populations that you're working with. So for me, working in, with communities that have been marginalized by most people, have sort of been pushed out, and, really thinking about that. But this idea of public engagement is around here. It's something that, when I talk to colleagues in other countries, they always highlight as something that is a positive about what goes on here. But I often find that people are not, really developing the kind of collaborative models of knowledge production that are helpful to this cause. And it takes time, building in that time and resource to gain and sustain trust with communities, because they have a reason to distrust. And especially major institutions. So, and also demonstrating respect for the existing leadership within communities, facilitating research with and by racial and ethnic minority communities. That it's not just about going to where, I agree there are various locations we could go to and within services, but it's what are we giving back? All of this information that we're gathering and taking from people, what are we giving back? So that I would say that reciprocity and those sustained relationships over time are incredibly important.
Thank you, Stephanie. I think it's really important that we kind of, as you're saying, sort of flip our relationship with kind of communities on its head a bit and try to be a lot less extractive, and it's about kind of how you work in kind of genuine partnership. So we've had a few questions around like funders and how what I guess is our message to funders around how to be anti-racist and more equitable in the way in which who they fund and what they fund. So, Frank? Oh, maybe I've lost him. Dawn, perhaps?
Of course. So, so you're talking about who should get how do you decide where the funding goes and who decides? And I guess part of the issue is that I alluded to it in my 2 minutes, is about if you don't have people on the funding panel, so the awarding bodies, the people who are actually screening the interviews at the point of, screening the applications and decided who gets the funding, and then further up, the people who actually decide what kind of topics are important and should get funded. If you don't have people who have insight and awareness of some of the things that we've been talking about, then what you determine to be good research comes from a particular slant of view of the world. So just to use my own example, why not? So some of you will be aware that I'm doing work with colleagues around culturally adapting psychological therapies. And when I wrote a grant application, one of my colleagues, a very senior person in my institution, gave me feedback which essentially said, this is a really great application, but I don't think it'll get funded because it's too niche. Meaning it was a relatively small number of people. So that's going back to Moise's point about the the minority label, that minority means it's not that important. So that niche bit. So presumably, had she been sitting on one of those funding panels, that's what she would have said, and I probably wouldn't have got the funding. See, but also, if I was in a different place at the time at which I was writing the application, I might not even have submitted it. So I do think that the very big funding institutions at the very top, they do need to have greater diversity, but they also need to take ownership for some of the things that we're talking about here tonight. So for example, the fact that you fund research that explicitly excludes people from ethnic minorities and other groups that are marginalized. So it will say things like, and one of the exclusion criteria will be inability to read and write English fluently. So that's not just a Black person's issue, that's issues to do with people who, for whatever reason, not completed their education. You know, this is a huge proportion of the prison population who don't read and write well. Young people, not so young people now, coming out of the care system, whose education's been disrupted. There are a huge number of people who don't read and write well. But you put that in as a criterion, and a whole swathes of people get missed out. And I think there are other similar things where, you know, it is about people trying to say, well, we can't do the hard to reach groups. We just need to make sure we have, you know, good representation, and we get statistical modeling and blah, 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 blah. So funders have some responsibility for what they fund, and they should be insisting that we use more creative ways of doing research that don't rely on excluding groups of people.
Brilliant, thank you so much. So my next question I'd like to direct to Chelsea and Saida. So we have a question. So if there was one thing that a researcher could do to be anti-racist, what would that be?
I'll go first, if that's okay, Chelsea.
Yeah.
I think really educating ourselves, and not just in terms of diversity and inclusion, but really thinking about what anti-racism is, how racism continues to operate within mental health services, mental health research, mental health policy, and really thinking about how we can use the knowledge that we have, the resources that we have, to try to deconstruct some of that, deconstruct some of the systemic racism that we see. Within research, that includes, I mean, like we've already mentioned, thinking about it not just in terms of how do we increase our representation, but thinking about it from, even when we're designing studies, who are we involving in that process? Who is involved in the research in terms of the research group? I mean, we need to think about the fact that lots of people probably won't actually participate in research because perhaps they've participated before and they've had all of their experiences watered down because it makes us feel uncomfortable, or even just thinking about the sheer exploitation that people of colour have faced by researchers all over the world and continue to do so. And if we are thinking about that, we need to also include more people of colour within that, and thinking about grassroots organisations as well, who can help us to actually really engage with these communities who are marginalised. And we also need to start thinking about some of the language that we use as well. So for instance, if we think about hard to reach, actually, are we really hard to reach? Or is it just that we're not engaging because we've been stung once already? We've gone to, you know, we've participated in research, but then we've read the paper and what we said was racism was written as perceived discrimination. You know, if my experiences are being watered down like that, am I going to participate in research again? And I think we all have a responsibility to really think about that and really acknowledge it and really give back power to the people who are participating in our research to be able to actually put their experiences out there and have it represented accurately.
Thank you. And Chelsea?
I would agree with a lot of that. I think sometimes we have to remember, what is the benefit for the person you're asking to take part in the research? I have been researched and documented since I was a child. I remember photographers like photographing us. And 6 months ago, the government didn't understand why that was a problem or a problematic research approach. They wanted to follow travelers around with cameras. And I think we have to, what is the benefit for them? But also, do the work. You have biases, you have all of that. Even go back to like deconstructing your basic understanding of knowledge, of research, of all of these things to understand where they've come from, but ultimately do the work. You know, there was an exchange on Twitter yesterday. I mean, Natalie spoke about this, where it's kind of often people will center their white fragility rather than kind of engaging with topics that it was more, you know, there's somebody that felt really uncomfortable that that this webinar was called Why Mental Health Research is Racist, rather than actually being concerned about the racism. And that's not uncommon, I don't believe.
Yeah, the fragility is so real and exhausting. Like, it really is. It really, really is. Thank you so much for that. Let's take another question. There are so many. And so we're mindful that you know, we've had loads of kind of questions coming through. So what we'll do is we'll probably, at the end, we will kind of, because there were some similar themes kind of coming through. So what we'll do is at the end of the webinar, we'll sort of work together to answer some of those for those who are still kind of interested. So I've got a question here. Is there any evidence, this is from Leah Ali, is there any evidence to show which interventions at the point of crisis make a difference to the number of Black, Asian, minority ethnic people being detained? Frank?
Sorry, I got dropped out my connection, so I missed quite a bit of the discussion, so I'm really sorry. So the question is, what should be done?
Is there any evidence to show what interventions work at the point of crisis?
I suppose at the point of crisis, you know, when people are confused, then it's about having other people there who can also have an input. And oftentimes what happens is families and people who know the person very well are excluded. And so I think we need to make sure, because oftentimes when a sectioning happens, you have the police there, you have the social workers there, you have the doctors there, but you never have the family there. Who can talk about this person, who can give input into that, and also talk about what supports they are able to provide. And if you exclude families, and particularly we know that in Black and minority ethnic communities, family is important for us. And so if we exclude the families because we're taking an individualistic approach, we're working with just the individual, that's not good enough. But I would also say we need to do much more to stop people from reaching mental health services in crisis point, because by then the damage is done.
Thank you so much. Let's see. Bear with me. There are just so many to choose from. So I've got one here that I think that a lot of people have been sort of questioning. So how do we embed these issues so that organisations don't rediscover racism again in 5 years' time? So the BLM movement, like, people now recognise that, like, racism is a thing. How do we continue to keep this on the table? And this is up for grabs, this one, people.
I think one of the things that we need to move past is thinking that we can just placate people of colour by constantly coming out with inquiries and recommendations. And I think we really need to start thinking about what are the barriers and trying to really overcome them and putting some of those recommendations into action. You know, for instance, we talk about, I think we've spoken about how the increased likelihood of Black people being detained under mental health legislation for about 3 or 4 decades now. And, you know, we've had so many recommendations for how to actually sort of try to address that, but that never gets put into action. And I think we need to start thinking about what are the actions that we can put into place. And I think a lot of that does include putting the power back into the hands of marginalized communities. And I think that's one of the biggest steps that we can take in trying to put some of this into action.
Thank you so much, Saida. I have another question here. This is from Jermaine Edwards. Jermaine says, as a mental health researcher professional from a low resource country, how does one advocate and represent mental health research from our context if the majority of the funding, such as PhD studentships, scholarships, projects, are more accessible to non-BAME communities? And Jermaine also says it's also disconcerting to read research done in our context without including mental health researchers from those countries.
So, excuse me, I think this is it's the same continuum, isn't it, as going into so-called minority communities in the UK or in Europe or North America. It's a similar idea, is that we're going to export our research, use the same tools and techniques, snatch and grab data, and then go back and analysing it all as though we're doing it in a lab. And I was really challenged, excuse me. Last year I went to an event in Ghana, and I was really taken aback by the extent to which Black African academics were internalizing this. So they, you know, I was the one going, yeah, but we can't just do that because what about the context, you know? And there is that kind of growth, that kind of push for what is seen as being excellent, and who's decided what is excellent. And if what is excellent looks like this, then that's what we must do. And then that becomes the global norm. So it takes all of us, I think, all of us on this platform to challenge that, whether that's in terms of the research that we do or the way we do it in clinical practice, is for us to say, no, we don't have a one size fits all approach. And if we know that and we keep on feeding the beast, then we become complicit in that process. So I think we have to start saying, no, you know, if I want to work with students from Africa, from the Caribbean, from the Middle East, wherever I'm going to work with them. And I'm not just going to use the same techniques that we use in the UK and export them there. We want to find new ways and model different ways of working with different groups of people if we really want to get to the truth of their experiences.
Yeah, that is so true. And it is that whole thing. It's like, it's so important to work in collaboration rather than having the grand takeover, because you even see that happening in the UK context. As Saida was saying, it's like, it might be really interesting to kind of do this work, or it's work that needs to be done. But the question is, are you best placed to do it? And it may be that your role is more as an ally as opposed to kind of leading on this work. And that, you know, that would be probably the most helpful thing, if people could just kind of ask themselves that, or ask somebody else to tell you the truth.
Yeah. Also, just to finish off, is just thinking about, you know, you talked about, Stephanie talked about reciprocity, I can never say it, giving something back, I'm going to call it, because I never say the other word. It's so important. You know, one of the reasons why I think Mose mentioned it, that sometimes, I know that I haven't up to now, very fortunate, had much difficulty working in Black communities. And I've had other colleagues going, can you help us to get into these communities? And I'm like, really? Is that what this is about? And if people don't get it, you know, people are not stupid. They've been over-researched by people who come, take stuff from them, go away, never tell them what came back, and more importantly, they don't see anything different. We've been researching inequalities, particularly in psychosis care, for 60 decades. No better. So why would I keep on doing it? So I think Stephanie made the point that you can't start at the point at which not even when you're writing your research application, people are starting at the point at which they're beginning to analyse the data and think, oh, we haven't got any Black people here, we just need to add another little bit of time, get a bit more funding and go and grab a few people to. No, it's tokenism, and people see through that. Partnership, genuine partnership, authenticity means you've got to put the work in.
I hear you, I hear you. So we're over time, but we're just going to spend a couple more minutes. So we're going to ask each of our panelists to, we've asked them to prepare a recommendation of an action that people can take who are in the research space to become anti-racist. So we've asked for what funders can do, what researchers might be able to do, what research participants, and also people who consume research. So we're thinking about policymakers and people who kind of develop interventions or services. So can I ask the panel if you in the chat could write who the recommendation is for and quickly pop that in. But what we would also like to hear from the audience, based on what you've heard this evening, what's the one thing that you're going to commit to move us towards mental health research that is more anti-racist? So if you could take a minute to do that, that would be great. And while you're doing that, as Andre's already said in the chat, we've had such a great response and so many questions that absolutely need to be answered. So whilst we're waiting for people to post what they're committing to do, I just want to thank the panelists for your insights, your honesty. We love #unfiltered. So that was great and really helpful, because actually that's the only way we're really going to move things forward. So before we go, let's just have a look and see what people are posting. So we've got Kata saying committing to authenticity. Oh my gosh, they're moving. And long-term partnership in my research to dismantle. She's dismantling something, so I'm assuming it's going to be the structures. So that's great. Yeah, and what we'd love is for you to kind of continue this conversation with us on Twitter. So if you look for the #MHQT, I'm sure the panelists also are on Twitter, so we'll be happy to kind of chime in and take kind of further comments. I didn't check with them, but I've just kind of volunteered them for that. So, hey, sorry. And thanks, I'll say thank you so much for joining us, giving us your time, your energy to kind of put forward your comments. And we look forward to continuing this conversation. So thank you so much.